So good morning, everyone. Welcome to our next session on When Issues Collide, Domestic Violence, Dementia, and Caregiving. I'm pleased today to have my colleague, Margaret MacPherson, with us to present today. Margaret is a research associate at the Centre for Research and Education and Violence Against Women and Children at Western University in London, Ontario. Margaret designs and develops curriculum related to multiple materials on initiatives to make it our business, workplace domestic violence programs, and as many are familiar with the It's Not Right neighbors, friends, and families for older adults. Margaret is very passionate in her belief that everyone has an important contribution to make in creating a safe and supportive environment at work and in our communities. I've had the great pleasure and continue to work with Margaret on many projects, not only within Ontario, but nationally, in development of not only It's Not Right and the work that she's going to be presenting today. So have a great opportunity to learn so much from her at today's session. I do want to make a little housekeeping reminder that I just discovered as we learn about the platform. For this presentation, in the corner of your black box, there is a little arrow that you can make this widescreen on your whole screen that will take up to see some of the slides a little bit clearer. So I will allow Margaret to take over and you can begin. Thank you for joining us.
Thanks so much, Rayanne, and hello, everyone. I'm so glad to be here with you today and have appreciated Amber and Jennifer's talks this morning. So I'm hoping that this presentation will add to the discussion and will stimulate even more conversation. I am going to cover a few things. I want to talk about gender-based violence. I want to talk about domestic violence. I want to talk about ageism and the social ecology of violence. Okay, I'll make that more fun than it sounds. And looking at the collision points with dementia and caregiving. And then at the very end, I promise, I want to talk about, okay, so, how can we think going forward about intervening in these very complex issues in good ways. So there's a number of terms that are used in, by different researchers in different disciplines. So you'll see different times in my presentation, I'm using the language the researchers are using. So domestic violence, intimate partner violence, spousal violence, and family violence, which is more broad, and then domestic homicide, femicide, intimate partner femicide. So these are terms that, reference roughly the same thing, but they have slightly different connotations and meanings and include different sort of groups of people. Violence against women and gender-based violence. So why am I going to start with gender-based violence? I'm going to go right to the NICE study that was done in 2015, looking at the prevalence of abuse of older people and point to a couple of things when they're talking about risk factors. So being female is a risk factor. And then, we see that in most of the cases, it's a spouse, a family member, a friend, or a neighbor. And the studies suggest that it is more often violence that's committed against women, although I think it's really important to acknowledge that people of all genders experience and commit violence, and the way that we address these issues needs to be looking at how do we engage everyone in the work of reducing the risk and in increasing safety. But for the purpose of my presentation, this is where I'm starting from, gender-based violence. I am focused on sort of the situations where you're more likely to have serious injury, hospitalization, and death. And so I'm talking about violence against women. And this is the Canadian Femicide Observatory for Justice and Accountability. Amber did a nice job of talking about all the great work that OAIT does tracking femicides, talking about them. This was a report done, so the Canadian Femicide Observatory looks at the numbers nationally, and this is from the last study they did in 2020, where you can see that half of the cases that they looked at were current or former partners. And that's remarkable because often when we're talking about elder abuse, domestic violence is not included in that, or just not really considered in the way I think that it should be. So I'll come to why that is. And then Amber did talk about sort of seeing an increase in the age, in older women who are being killed. So you can see on this graph at a national level as well, these are some of the highest rates are older women, and it has been changing. So, as the population ages, we become more concerned. This is a book that I contributed a chapter to, Preventing Domestic Homicides, and it's just a note from the foreword that I have up on the screen, because I think that, there's been research done for many years about how to prevent domestic homicide, and there have been inquests and death reviews and the same recommendations being made over and over again. And so it's like, we know what to do. It's the figuring out how to do it. How do we move a system upstream toward prevention? That is really the thing that occupies a lot of my thinking about steps that need to be taken so that we can actually move to prevention. This was the chapter that I contributed to that book, Older Women and Domestic Homicide. So I'm just going to do just a little surf over some of the things that are discussed there. I think it's important to note that domestic violence in older life, in later life, can occur in two contexts. So most often we talk about the history of domestic violence, where it's been there throughout the relationship. And then researchers have found, there's situations where what they call late onset. So it begins in later life. And so maybe that's a new or existing relationship. And retirement has been linked to this. Retirement is such a large life change. And one of the things we see is that as men retire from work, because of ageism, they take their place with women as less valued members of society. And so their experience of violence in relationship numbers can go up. And then with the history of, when domestic violence has been present in a family, it does change over time, so that when people are older, it may be more psychological violence. And unfortunately, that's still seen as being less harmful by many people. And older women themselves really anyone who experiences psychological violence will say it can be just as devastating as physical violence, sometimes more so, because it erodes your sense of your sense of self. This is a quote from Charmaine Spencer, because I do want to talk about ageism as a social norm that has to be really understood as how it influences violence and abuse of older people. We don't question the basis of our attitudes and beliefs. Just think about your own, sense of getting older. Are you excited to be getting older? Do you look forward to, the time in life where you may need supports around you? These are things that we spend a lot of time and energy trying to avoid. And so we incorporate these, we internalize these attitudes. Getting older sucks. It's awful. It makes you dependent. And, it contributes to this sense that older people are less valued, which comes from a very strict sort of capitalist system that only values people who are, paid earners, those sorts of things. So we've internalized these attitudes. Bridget Penhall has described ageism as kind of a sort of in the sense of a triple threat of being a woman, being an older woman, and then being an older woman experiencing violence. So, and then you have the intersections of oppression there, where Amber talked about, you see higher prevalence rates in people who are racialized, Black, Indigenous women, differently abled, neurodivergent people. Like, you see intersections of oppression that make you even more disadvantaged. I do want to talk about structural violence and the idea that, you know, we're still this lingering idea that domestic violence really is about younger women. And in part, that's due to the systemic ageism that's embedded. And we see that in things like global and national surveys not that long ago that we're only looking at including women up to the age of 49. So everyone over that age was invisible in this research. That creates a domino effect because, you know, funding follows the evidence. And if there's no evidence of abuse of older women, then there's no funding to support them. And we certainly see that in the lack of resources, you know, specific to the needs of older women, older people who may be experiencing violence and abuse. There's also gaps in the research. Like, when we talk about abuse of older people, there's a 40-year age range that we're talking about. You know, there are significant differences across that span that sort of get lumped in together. We're looking at three sometimes competing paradigms that the research comes out of: social gerontology, geriatrics, and the violence against women sector. And so it creates different perspectives on a similar issue that makes it difficult to have a cohesive analysis, discussion about exactly what I started with. How do we move toward prevention? And then there are cases that we see in the news where, you know, it's described as mercy killing or a suicide pact because the couple is, you know, experiencing health issues or financial issues. But the research shows that most of the time, these are anything but merciful deaths. The women don't agree to them. And, you know, it's part of this, I think, sort of similar to the caregiver stress idea that that killing can be justified. So, you know, all of these things are sort of swirling around in our attitudes about older people and violence and abuse in their relationships. It's true that the number of older women who are killed by their male partners is the hardest kind of proof that domestic violence is a significant gendered issue, and it is getting worse as the population ages. And so it's incumbent upon us, I think, to learn about what it means in later life and how we can respond well to it. I'm going to show you a little scenario right now that shows a family situation. I always ask people to watch for warning signs, things that make you concerned for the family. And so this is a son and a daughter who are showing up at their parents' house. There are subtitles on the video if you are having trouble hearing it.
Hey, Mom.
I'm waiting.
Oh, I'm coming. Your father's always been so particular about his tea.
You gonna invite them in this time? Or are they just gonna stand out there with their coats on like a couple of strangers?
The old man's as tearful as usual, I see.
I told her we couldn't stay. I've already had about all I can take.
Oh, it's a new record for you.
I'm trying to beat yours.
Oh, it's so good to see you both.
I don't know why you still let him talk to you like that. You should have left him years ago.
Oh, she's stronger than that, aren't you, Mom?
Are you sure you can't stay? I can make you something to eat.
They wanna go, let them go. Good for nothings. The three of you.
Ah!
Christ.
Could you have made it any fuller? What's wrong with you?
Ow! Oh, I'm sorry.
We literally just stopped by to say hello. We have to run.
Well, don't wait so long between visits. We never see you.
Well, life happens, you know? That was fun.
Still want to get that drink?
Oh, yeah.
Skies today with brisk easterly winds. Expect a high near 52 degrees.
Oh, so there's lots of things that we can talk about in that scenario. And the scenarios were designed exactly for that purpose, to spark discussion, to give people stories to look at and think about the people who are involved in them as a way to talk about the issue in specific ways. What is the situation? Okay. So we can see that there's a history of domestic violence here. Phil's health is failing. He's becoming more dependent. There's a question about sometimes I've heard people talk about, what if Pat starts to, hurt Phil, after years of abuse? Is that any less of a concern? But also, as Phil loses his independence, the abusive behavior may escalate. And the challenges that Pat faces, power and control are normalized in that relationship. She's maybe finding herself increasingly trapped by his deteriorating health situation and increasing dependency, and with an expectation that she will be the one to look after him. So the adult children, they seem to be distant and unavailable through, trauma in the family over years. Does she know about supports that might be available to her? And if she does decide to leave, are there, this slide has been here for a little while, and I have to say that there's a lot of work being done in the shelter system to address this, but it is a question from place to place, because the whole system is under-resourced and struggling to meet the demands. So, what is available to Pat in the community in her shelter, if she decides she wants to leave, and then, what will happen to her husband. We also have to consider the health impacts that, it has significant impacts on older women, and, especially when they have prolonged exposure over the course of their lifetime. And I think that this is changing, but, when I'm in community settings, talking to healthcare people across sort of human services, we're still really not educating on domestic violence in older couples in particular. And unless there's a sort of real training that happens on being able to identify warning signs, being able to look past things that can be sort of attributed to age-related illness or deterioration, that we're not prepared to see domestic violence in older couples showing up. I think Amber talked about this as well, that, this is another stereotype that older women don't experience sexual violence, and that's not true. And sexual violence is a high risk factor for homicide when it's in the relationship. Older women, aren't asked or about, or, STIs and HIV testing doesn't happen. People don't think about it because it's not on people's radar. We have these stereotypes about sexual violence. And it is very common in domestic violence situations. This has also been discussed, sort of all the barriers to reporting. And that's, from a systemic level, also goes to this idea that people aren't expecting it. And so what we do know is that it is the attitudes and the beliefs of the people around the family that can make a real difference in terms of encouraging them to seek help. So, what you do as an individual service provider can really influence the situation. Again, barriers, lots of barriers that are specific to older people. And I think that, some of these, the fear of ending up in a senior's home is so powerful. The stereotype, the ageist attitudes about, the phrase domestic violence grown old, as if somehow that means it's not worth considering. The internalization of blaming yourself for the situation, feeling shame about that. The fear of separation and change, older couples who are being separated. All of these create barriers that make a difficult situation even more difficult. And of course, it's a generational thing. Understanding violence and abuse in relationships, we've come a long way in the last 30 or 40 years, but women are still surprised. It's not just older women too. I think that lots of people don't recognize the danger that they're in, and older women in particular may be surprised to learn that their experiences are worthy of attention or services. As older women age, their horizons for action diminish, and they see themselves as having fewer life choices within the scope of decreasing power. What a sad, state for older women, so many older women. I wanted to spend just a couple of minutes talking about the Canadian Domestic Homicide Prevention Initiative and how domestic homicides differ with older adults. There has been limited research for all the reasons that I gave around not paying attention to domestic violence in older couples. But there has been some research done. And what we find is that the couples are most often in intact marriages. The husbands are the large majority of the perpetrators. Physical health problems are common. The perpetrator is depressed. There's dementia with the victim. And there's a caretaker role that's unfolding in the family. You can see that in that's the Domestic Violence Death Review Committee in Ontario that has done this research and found that you can see the likelihood of it being a homicide suicide goes up in older couples. And I think that professionals are often trained to ask about suicide, but not trained to link it to that. If it's a situation where there's also domestic violence, the chance for suicide, homicide also goes up. And then the risk factors are different. So I really appreciated Jennifer's presentation this morning and the tool that's coming, the HOPE tool, because understanding the different risk factors, particular to age groups, is an important part of generating the awareness. This was a recent study that was done around COVID-19, and again, identifying risk factors. Access to firearms is huge, and understanding that living in rural and remote communities, your risks go up. Some of the recommendations coming out are about screening for depressive symptoms, suicidality, alcohol and substance abuse, screening for domestic violence and access to weapons, and referring to specialized mental health professionals. The DVDRC has come out with recommendations over the years, pointing to the need for enhanced education and training, and the need to be teaching everyone, because what we find is that in cases of domestic homicide, intimate partner femicide, it's almost always the people right around the family who see what's happening, but they don't know what to do about it. And so we need to be training professionals, but also the broader community to recognize warning signs, because it is preventable. Because in most of the cases, we see there are risk markers. There are indications that have an evidence base to say this is a situation that's escalating that needs intervention. So the critical information that's held by family, friends, colleagues, and frontline professionals needs to be grasped, understood, and acted upon, which requires the collaboration. So Amber I heard her talking about the networks, the elder abuse prevention networks and the violence against women coordinating committees. The community coordination piece is fundamental to be able to move the system upstream toward prevention. It's not very well resourced or not resourced at all because we are structured in our systems to address the issue in sort of silos and disciplines. Learning how to work collaboratively, collectively is part of the learning that we need to do. This is just another slide really that talks about who knows what's going on. And you see that in people who are 55 years and older, again, yes, police have some awareness, but for the most part, it's family, friends, coworkers, neighbors who are aware of the situation. And so out of that evidence base, this was the development of It's Not Right, Neighbors, Friends, and Families for Older Adults. It was adapted from the Ontario Public Education Campaign, Neighbors, Friends, and Families. This was a pan-Canadian project that the federal government, the Public Health Agency of Canada, funded a number of years ago for us to adapt and make the resources available. We partnered with the Canadian Network for the Prevention of Elder Abuse, and we talked to people all over the country about what do people need to know to be able to respond when they're concerned about an older person in their life. So I point you to this resource. I'm not going to spend a lot of time on it, but it is designed to teach everyone about warning signs. This is really fundamental. You have these very complex issues, and the research is clear that if we can teach people 1, 2, or 3 sort of actions, we can interrupt what's happening. And so teach everyone to recognize warning signs. Teach everyone to be able to articulate, what does abusive behavior look like? It's so common. It's become so common in our society, the way, it is sort of propelled, it seems to be without question, that it has become normalized. And so I think that part of what we need to really do is being able to recognize abusive behavior, to name it for what it is, and to address it in that way. Coercive control, understanding the difference between conflict and abuse, between coercive control, where you have, these are the highest risk situations where the greatest injuries are done. It is where you have one partner who's using a pattern of behavior to be in control of the relationship. It has been called by one researcher intimate terrorism because it's so focused. It is, sort of a terrorizing of the other person. And it has the highest risk. So we do focus, when we're talking about domestic violence, training on domestic violence, that people need to really understand the dynamics of coercive control. Probably the hallmark of this is that victims live in fear, and they're going to change their behavior as a way to try to manage the ongoing threat of violence. So I'm not spending a lot of time on these things. I just am flagging them for you, that these are this is the information that people need to understand if they're going to be able to recognize warning signs and risk factors. This is from the Domestic Violence Death Review Committee in Ontario, looking at cases reviewed over many years. This is where the statistic came from that says, yes, it's preventable because we see the same things over and over and over again. So on the left of your screen are the most common risk factors for lethality. And so when we see these things showing up in a situation where there is domestic violence, people will say, well, I don't think it'll get that bad. But what we want people to understand is that when you see this kind of behavior going on, you need to act as if everything is possible, as if these are lethality factors. In a sense, it compels you to take action. And so doing good risk assessment to understand the specific dynamic risks that you're dealing with is fundamental to getting to prevention. And does a coercive control lens change the way you think about this situation? It's a question really that begs discussion, amongst people who are, trying to manage the situations. I just want to take a minute to say it's also really important that we do have a larger view on this. It is not just an individual issue for Pat and Phil. We have to consider the relationships around them, the community around them, and the society. All of these sort of levels of our world impact on people, impact on their lives. If we just look at domestic violence as an individual issue, what the tendency is to, talk about Pat as allowing the situation. Well, why doesn't she leave? What is, why isn't she doing something for herself? Blaming the victim, it's very common. And then, Phil, he's a bad person. You can't do anything with him. Once this happens, there's nothing that can be done. Like there's real problems with focusing the issues only at an individual level, when in truth, what we're talking about is the complexity of, the full ecology, where you have deteriorating health situations, shifting power dynamics in this relationship, estranged relationships, the children aren't very involved. What are the financial dependencies that are present? And in the community, what housing is available, if the couple were to split up? What are the social expectations about Pat's role in the community to, look after her partner? If it's a small community where everybody knows everybody, wanting to not be seen, not to be outed, that this is happening is likely. And there's, going to be fewer resources. And then at a social level, the tremendous amount of unpaid, underpaid care work that goes on that falls mostly to women, speaks to the ongoing sexism in society that is also part of the structural violence. The economic pressures that people are experiencing right now, let's be real here. The research is clear that when people struggle to survive, violence rates go up. These things are not disconnected. And so, when you live in a world where income goes to the top 1% of the population and everybody else is kind of struggling to survive in an increasingly expensive world to live in, we're going to be cleaning up the mess all the time. And so the inequities that are in society kind of set us up to be dealing with these things. And then, of course, you have ageism that pervades all of this that I've been talking about, and health inequities in terms of who's able to access health. All of these things contribute to the situation that Pat and Phil are experiencing, and I think need to be part of the conversation. We all need to understand the way in which our lives are. Yes, we are all responsible for our own lives, our actions, and there are many factors that contribute to the disadvantages and and advantages to be able to, live a good life. And so I come to the end of this little section really with a series of questions that could be asked in a room with, a group of service providers to consider, how does risk change when the health issues force one partner to be caregiver to the other? When the historical abuser is the caregiver, when the victim is the caregiver? How prepared are people in healthcare, other sectors as well, to be able to recognize and respond to domestic violence? What I've seen over the past few years and what I've heard from service providers is, in some ways, we've lost ground in some significant ways because of austerity measures over time. The social safety net has been hollowed out. And so people are struggling, to provide service in sectors where the demands for service are increasing. It is a bad situation. And I know that sounds hopeless. I am going to get to, thinking about what else we can do, but I want to take a couple of minutes with a couple of other scenarios just to, add to this story. And so this is Pat and her daughter now at a doctor's office. So just watch for how the things maybe we've been talking about show up in this situation.
What time is it?
It's 12:15. We'll get some lunch after this.
Where's my purse?
Here you are.
Oh, thank you. What time is it?
It's 12:15, Mom.
We ought to get some lunch.
These are the resources for people living with dementia I was telling you about. Your mother's going to need this as her dementia progresses. I need you to make sure she takes her medication exactly as prescribed.
Can you please explain that to her?
Listen to me, Bubby. You have to be more careful with your pills, okay? She needs to take one at breakfast.
Can you tell her?
Take one with breakfast, one with lunch, and one with dinner. Only 3 a day. It's important she understands. Do you understand, dear?
What about my memory? I'm having trouble remembering things, and I can't sleep at night.
You have to take your pills, dear. We'll see how she does with that, and I'll have you back here in 6 weeks.
Well, that was helpful.
Again, these scenarios have been created to spark discussion about, what do you see happening? How does ageism show up in this scenario? How does that doctor, regard his patient? And what does the dementia diagnosis mean? Does it just a matter of taking your pills, like, Pat's asking some questions that aren't really responded to? There's a lot happening in this situation. And all of the situations, these scenarios that we've developed for the It's Not Right campaign were developed out of real life stories. So, these are things that are still happening. And so talking about them and being able to point to the places where ageism, sexism show up, I think are part of our collective education that needs to be taking place. So, again, we're seeing collisions happening here around assumptions about dementia and Pat's ability. Ageism is present, sexism possibly because she's a woman, but you really see the paternalism in the way in which he's talking to her. All of these things undermine, Pat's ability to see herself as a full person. What is the impact, I think, is the most important question that we can ask out of every encounter. What is the impact of my questions, of my observations, the conversation itself? And how is this going to change the relationship between Pat and Ellen? Remember, they have a kind of estranged relationship. So, sitting in that office, all that the doctor is seeing is a daughter and a mother. None of that backstory is present with them. And so, it begs the idea around, I've heard it said, I see it on people's sort of signatures, treat everyone with kindness because people are everyone is fighting a battle of some kind, that sort of idea. I think Amber talked about the link between dementia and domestic violence. It is under-recognized and incompletely understood. It is not a new problem, but again, it tends to be conveniently ignored, because it's ageism, because it's happening in older women. Like it just doesn't get the attention. We're seeing a lot of attention around sports athletes, right? And how they are affected. But little discussion about the many women who are going to suffer a traumatic brain injury as a result of intimate partner violence. And people who suffer a TBI have these kinds of symptoms. So Amber said, ask people how they're sleeping. It's a great question that kind of can open the way into the conversation. And, we have to think about how the relationship between them. Because ultimately we do want to change the conversation to make the link so that people can see the relationship between dementia, domestic violence, and things like traumatic brain injury, so that we can meet the needs of older women who move into the service system. Yeah, so this is still borne out. I do think this is changing, but the pressure to do training in a consistent and ongoing way speaks to, again, a system, a service system, a healthcare system that is struggling just to, meet the needs of people coming through the door every day. It's a tall order in, our current situation. So again, these are questions that are designed for community discussion and, people coming together to figure out, what dementia means in the context of domestic violence, and what can we do, how can we respond, and what does it mean for the couple? What does it mean for Ellen? I'm going to show one more scenario here. I think I have one more, where I just want you to follow let's follow Ellen's story for a few minutes.
Hi, it's Ellen. Do you have a minute? Yeah, I'm at my mom's and I'm exhausted. I've been here all week. Yeah, they discharged her from the hospital because they said that she doesn't require acute care. They've deemed her alternative level of care because they say other people need the bed more. Well, I'm getting enough sleep. I mean, it's not just that. It's nothing that I do seems to be the right thing. I try to get her to eat every time she's here, but she's just not hungry. And the health nurse was here yesterday and said she's still losing weight, like it's my fault. What am I supposed to do if she won't eat? I even made her chicken soup, which she loves. She wouldn't touch it. She gets upset every time I try to feed her. And the accountant called yesterday about a check that I helped her to write at the pharmacy, implying that I was getting her to pay for something for me. And my brother seems to think that it's my responsibility just because I live nearby. He won't lift a finger, but he sure is ready to tell me when I'm doing something wrong. I drive her to all her appointments, make sure she takes all of her medications. I try to get her to go for a walk, some exercise, but she complains every step of the way. She's not getting any better, and I don't know what else. I don't know what else I'm supposed to do. I can't take any more vacation time, and my boss has already been very understanding so far, but I can't see this becoming a problem really soon.
So lots to talk about what's happening to Ellen. What are the implications for her? Why is she, what are the expectations coming at her around looking after her mother? We don't know what the situation is with Pat and Phil at this point, but just dealing with her, the issues around her mother are considerable, and then you have the complication of, the couple. So lots to talk about in terms of what you're seeing, what stands out for you in this situation, and what can be done about it. So the collision points, right? History of domestic violence, the estranged relationships. There's now a dementia diagnosis for her mom. We see ageism in the way that her mom's being treated, in the assumptions around what dementia means, and the available resources for the family, for Ellen, for her mom, for her dad, right? caregiver expectations that Ellen's going to step up here, but she has a job, and her job is coming under pressure now with the demands on her. How many people are experiencing this? We have the intergenerational cascade of trauma and the impacts. And this is a cascade that cuts across sectors. Like, it's not just one sector that's involved. It's all of society. And that's why we need, I think, this bigger view about the way in which societal factors contribute to putting people in these situations that seem impossible. So yes, it's complex. There's all these elements and all these different pieces that need to be considered and considered in relationship to each other. But at the heart of it, it is about people. And who is in a position to talk with each of these family members about what the situation is, about reducing the risk for violence and increasing safety across. It's a human being approach that we need in the face of, systems and standard practices that I think we underestimate how powerful it can be to be able to talk about what's happening in a meaningful way, and to be able to talk specifically about the risks that are involved. So what are the important questions and conversations in your community? What opportunities do you have to bring multi-sector professionals together to talk about and to strategize solutions? I've been doing a number of workshops recently with multi-sector groups in communities, the coordinating committees, the networks, and I find there's incredible value in people talking together about what they do and how they resolve situations, and how they can work together more effectively. There is not a lot of support for this. I think we need to be advocating for it. It cannot be expected to do this sort of community coordination work without any kind of resources. And so after I say all this, how do you feel? Like, how do you identify with this picture in terms of, oh my God, what are we going to do? It just is so overwhelming. So I have to say, I want to spend a couple of minutes talking about the possibility of change and the necessity of it, because, human beings are amazing. When impossible situations come, we figure out how to make change, how to move forward. I wanted to reference Future Us. It's a pan-Canadian engagement strategy in which we talk about, it's true that everyone has a role to play, but it's a meaningless statement unless people understand what role they can play. And being supportive, we underestimate how one supportive person can make such a big difference. So I want to go back to the scene with Ellen and just give an example.
She's not getting any better, and I don't know what else. I don't know what else I'm supposed to do. I can't take any more vacation time, and my boss has already been very understanding so far, but I can't see this becoming a problem really soon.
Oh, no wonder you feel exhausted. It would be too much for anyone. Listen, what would you say if I got our friends together to find out what other help there might be in the community? I'll organize a brainstorming session, and you won't have to lift a finger. Would that help?
Yeah.
People are so often alone, struggling to deal with these very complex situations. Even one supportive person can make a difference. So the Canadian Network for the Prevention of Elder Abuse launched Future Us as a roadmap to the prevention of elder abuse this past year. We set 3 goals. It was a collaborative group that worked on it and identified 3 goals that can guide the way that, need to be taken up and acted upon in every community. We do need to prioritize prevention in every community. So what can you do in your community? What's already happening? We do need the infrastructure of elder abuse prevention networks at local, regional, and national levels. These networks, these coordinating committees are essential to the work. The death reviews, the inquests say this over and over again. We have to be working together across disciplines and engaging the entire community. So teach everyone, no matter where you are. You start out as a citizen, as a person in this community. You should know how to recognize warning signs, how to respond safely and effectively, how to talk about what's happening, and where to find help in the community. In terms of forward thinking, the Canadian government has made a lot of investments to develop health equity-oriented curriculum that acknowledges these kinds of intersections as health issues that are persistent in relationships, in systems, and society. And so equity-oriented education across the disciplines, I think, is a strategic direction that has the potential to bridge long-standing research and sector tensions by anchoring the education in human rights. It provides a foundation for the development of shared principles and practices using a common language that is well-versed in the relationship between a person's unique social location, the trauma that they've experienced, and the violence at all levels of society that they may be experiencing. This is two resources that I can point to, the Gender, Trauma, and Violence Incubator at Western and Equip Healthcare. This is the website on the Canadian Public Health Agency of Canada. It's Trauma and Violence Informed Approaches to Policy and Practice. So trauma and violence informed care is an innovation. It's a Canadian innovation that builds on all of the great work that came out of the States, mostly around trauma informed practice. What's important about this is it lifts it up to the system level so that we're talking about systemic and structural violence in that larger ecological sense, if we're going to get to real sort of effective prevention strategies. And so there's lots of good information there because, as I said, it's not just an individual issue. Your organizations can consider the principles around becoming trauma and violence informed. What are your policies like? What are your practices like? This is just, I'm pointing to, they've developed curriculum. Colleen Varco is one of the researchers. It's free. It's online on the Equip Healthcare website. You can learn a lot about becoming trauma and violence informed there. You know, these are the principles. They're accessible. Anyone can practice them. You know, understanding that trauma, violence, and its impacts on people's lives and behavior. This means learning about sort of the structural violence, all of the complexity in people's lives. Being able to create culturally safe environments, fostering meaningful choice, collaboration, and connection, and adopting a strengths-based and capacity-oriented approach. This is what can bridge the divide between disciplines and mandates if we're all working on, these ideas. We can become trauma and violence informed with universal precautions, understanding that everyone's had trauma of some kind. You don't have to know their story to be caring. People don't do things without a reason, because it goes back to that idea about, encountering people, meeting them where they are. Like, we know these things, but we have to practice them in a way that moves us from being kind of working machines, which is, I think, the way we're kind of produced in our society right now, to to being a point of intervention where a kind word, support, can really make a difference in a person's life. And we have to learn to manage risk as a community. So teach everyone, and learning to manage risk as a community is an important strategy. I've seen lots of great conversations happening where multi-sectors are coming together to develop a common language around risk. I think the HOPE tool will be really helpful, to be able to manage risk as a community. Too often these very complex cases become like a hot potato that no one wants to deal with, and the mandated services kind of end up holding the bag. You know, our entire service system, our violence response ecosystem is crisis oriented currently. We have to move to prevention in the small ways that prioritize relationships, that relationships are the currency that we need to be supporting and developing, not just for the people that we serve, but for ourselves as well. You know, we're seeing people leave the sector in droves, leave the work because they're burned out. It's too much. And so a care economy is where we need to go, working together on complex issues, not expecting any one person, sector, organization, or community to solve it. It is a matter of having a lot of different pieces and learning how to put each piece together. Everyone does have a role to play. You need to understand what your specific role is, what you can contribute, how we can hold each other accountable for the piece that we can do, and moving forward in a good way. These are some of the perspectives gleaned from the death reviews. We do need to take domestic violence in older couples seriously. They may be more reluctant, experiencing more kind of dependency. Screening for mental health and physical health problems, screening for access to guns, understanding that minor changes can reflect major issues. Addressing the basic issues in safety planning and risk management. Not everyone has to become a professional risk assessor, but we all need to be able to recognize risk. And then I think we also need to be advocating. The crisis-oriented system that we're in is the most expensive system possible. We cannot be waiting for after the fact of violence to act. And, you know, engaging the governments in this, I think, is important, but there's lots we can do on the ground in our communities to remember that we're talking about people, we're engaging with each other. We need to support each other and the people that we encounter in some fundamental ways that if we put our energies together, we can, I think, find hope to, you know, weather the storms that we're in right now. So that is the end of my presentation. I see I'm like pretty close to on time.
Thank you, Margaret. We do have a few questions that did come in. The first one is just about research, just asking in regards to late onset of domestic violence, is there research on potential historic, psychological, or emotional or financial abuse? And what types of violence are tackled in that research, if you're aware of that?
Yes, there is research. I'm not sure how I can answer that. There's not a lot of research. Like it was surprising to me when I was looking at some of the death reviews that there are these cases where there doesn't seem to be a prior history of abuse. So there is some, not a lot.
Thanks. And then just sort of looking at domestic violence in a whole context, does some of the programs and information or research that you've been doing include 2S LGBTQ and non-traditional families relationships, and in a company as well as same-sex couples as well? Yeah, absolutely. There's more and more research being done, I think, that moves us into looking at all kinds of families. As I said earlier, domestic violence cuts across all groups and needs to be understood as such. So I think that we're in a good way moving forward. When we focus on femicides, homicides, the stats are still pretty clear that the majority of the families are going to be male perpetrated, female victims, but it does happen across all groups. So, we need to be more supportive of research across all of the groups. Thanks. I know there was a comment just about, lack of affordable housing and financial means for people to leave as a barrier. And I think both yourself and Amber had mentioned that as well in your presentations. And it's something that, a systemic issue that we do continue to need to address as well. There was just a comment about is neglect in, sorry, I'm just trying to bring it up here in the chat box. Is neglect in a hospital setting also considered to be an abuse situation?
By a family, like by a family member, like
We are neglect in healthcare be considered domestic violence? Sorry.
No, no, I wouldn't consider it that. That's its own category.
Okay. And what was the other one? Just people just asking, thanking you for your wisdom about in such a compassionate way, and how that we all need to, we've all been raised sort of to work like machines, and that burnout is unfortunate that does happen. So we do recognize that and appreciate that. There was some questions just in terms of the INR and access to say maybe some of those videos. Can you just comment on the importance of the training and how people can get information and resources on that training and then the videos after?
So I would suggest you contact Rayanne. Elder Abuse Prevention Ontario does training in the province. So if you have you have people from all over at this. Yeah. So if you have a provincial or territorial network, I think all of them do. It's not right training. It's really, we do want people to do training to be able to use the resources in the way that they were intended. You can also contact me if you're interested in it. I also want to say that this today, what I've done, it's a kind of a thinking about this. I'm thinking about creating kind of a template for these resources for you to use in communities to spark these kinds of discussions, like the scenarios. It's so valuable to bring multi-sector groups together to talk about how they would respond to each of these. Like, it's just, we need to be talking to each other more. And I think this might be an opportunity to do that. So that's something that's in the offing. It's not there. You've seen sort of the prototype today in terms of the pieces, but I'd like to put it together into a template that, we can make available to community folks.
Thanks. And I think just to build on that, that importance of, working across sectors and disciplines is, Margaret's also going to be facilitating the workshop tomorrow with Jennifer, and, having input from those diverse sectors and have, just exactly what both Jennifer and Margaret have been saying about, getting understanding what people's roles are and how we can, collaborate and, identify some of these risk factors, and knowing what our role is in regards to that, I think is really important. So, I know that we're almost at max registration. I just looked before this session. So if anybody's interested in that, learning more about that, sort of that risk factors and assessment, please take part in that. And the last question, do you have any tips on direct questions that you can ask a senior that is saying that they're being abused? So how would you approach that? And I know we are going to have a session this afternoon with David Burns, who's going to be talking about that a little bit deeper. But if you have any comments just based on, I know the work that you're doing with the It's Not Right program, and I've put the website up for people to access some of the brochures that talk about that. But just maybe one last comment on that, Margaret.
I do find it's helpful for people to have ideas about what to say. And so that is part of what we do, is we give people ideas about how to approach the conversation. We do have a framework, a conversation framework about, I see what's happening to you, naming warning signs, and then asking, if people want to talk more about it. Like, there are ways to approach it. I can't sort of pull it right now, but I say, yes, if you know, and we're trading on the relationships. You are probably in the best position to have the conversation, right? So the person, but I think that we can support you in how to have that conversation. What do you want to happen as a result of it? We're not asking people to solve other people's issues and lives, right? But we are saying that being a supportive person, opening the door for conversation, it really does make a difference.
Yeah, For sure. Thank you so much, Margaret, and everybody for attending. Again, Margaret will be around for a bit on the platform. Again, just to, if you want to network, ask questions in the speakers section, you'll find Margaret's name and you can start a dialogue there. So we're just going to be taking a half-hour break for people to grab something to eat, and we'll commence back at 1 o'clock with Peter's discussion on financial abuse and risk assessment on financial tools. So that should be an interesting conversation. So thank you again to our ASL support as well as Margaret, and we'll see you back in a half an hour. Thank you.